Hello, here I'm going to give you, as briefly as possible, an introduction to the Milan system for reporting salivary gland cytology. Well, first of all, we will have a quick look at the overview in terms of its conception and the aims, and then we will just jump straight into the Milan categories. Let's start with the overview. This is a system that is born out of the collaboration of more than 40 participants. This includes pathologists, eminent head and neck pathologists in 15 countries, as well as clinicians. And it was published in Acta Cytologica in 2018, followed quite shortly by the publication of the Milan system for reporting salivary gland cytopathology, the guidelines. And I do encourage you to get this book because it does have the explanations of the categories in more detail. So this is a practical classification system that is evidence-based, and it aims to create a system of standardized reporting so that we can stratify cases into risk of malignancy in order to facilitate a management algorithm, and not only that, but also quality assurance and clinical audits. Now let's go straight into the categories. It is a 6-category system, although if you see here, the Neoplasm category is actually split into benign and salivary gland neoplasm of uncertain malignant potential, or SUMP. So the categories are Non-Diagnostic, Non-Neoplastic, Atypia of Undetermined Significance. This essentially means you can't exclude a neoplasm fully. Neoplasm, which is divided into benign and SUMP, suspicious for malignancy, and finally malignant. The authors stress that the reporting system should emphasize risk stratification rather than specific diagnoses, because they do realize that in salivary gland cytology there are specific conditions that are not able to be diagnosed on cytopathology, perhaps due to the low-grade nature of the neoplasms or due to the requirement to evaluate the capsule of the tumor for invasion. So let's start by looking at the first category, which is non-diagnostic. Here is the definition. A non-diagnostic salivary gland aspirate is one that for qualitative or quantitative reasons provides insufficient diagnostic material to provide an informative interpretation. This is a direct quote from the Milan book. First of all, we have to ensure that all cytologic material is passed before we put something into this category. The estimated rate of incidence, or something that we should aim for, is less than 10%. There are no established specific criteria for inadequacy. However, the authors kind of follow along the lines of the Bethesda for thyroid, and they mention that if there are fewer than 60 lesional cells, it is likely to be non-diagnostic. In terms of the qualitative nature of the aspirate, poorly prepared slides with artifacts also preclude accurate diagnostic evaluation and hence can be regarded as non-diagnostic. Now, what are some of the cytologic criteria for a non-diagnostic smear? For example, if we only see normal salivary gland elements, but the clinical or radiologic setting shows a definite discrete mass. Here is an example on the alcohol-fixed Papa-Nicolau stain smear, showing you the grape-like appearance of the acini, a small duct here, and also some vascular and adipose tissue stroma. Also considered non-diagnostic is cyst, which is non-mucinous and without a well-preserved epithelial component. This can be reported as non-diagnostic, cyst fluid only. And here is one such example where you can just see macrophages. You do not see any mucin in the background or well-preserved epithelial cells. Hence, we really cannot make a call regarding the nature of the cyst. Now, when can't we call something non-diagnostic? Number one, if we have a cyst, but it contains mucinous material, even if there are no epithelial cells, this should be more safely classified into the AUS, or Atypia of Undetermined Significance category, because of the possible chance of low-grade mucoepidermoid carcinoma. Where there is any significant cytologic atypia at all and we can't fully exclude a neoplasm, again this should fall into the AUS category, even if the smears are very hypocellular. And if we see a lot of inflammatory cells, even if there are no definite epithelial cells, this may be classified as a non-neoplastic condition. And finally, if you see some stroma or matrix component that suggests a neoplasm, even if there are no epithelial cells, this should not be considered non-diagnostic. The management is to repeat the FNA under ultrasound guidance. If this repeat is also non-diagnostic, then consider imaging, high-resolution CT scan, for example. If there are any features at all clinically or radiologically that are concerning for malignancy, then further biopsy may be considered. Core needle biopsy, open biopsy, or even surgical excision. And if the reason for the sample being non-diagnostic is cyst contents only, then it may be a good practice to aspirate this completely under ultrasound guidance and then FNA the residual solid areas. If the cyst disappears completely, then patient can be followed up with ultrasound with or without FNA depending on the clinical scenario. Now moving on to the second category, which is non-neoplastic. Here is the definition: specimens that show benign non-neoplastic changes, including those associated with acute or chronic reactive responses to inflammation, structural alterations, and infection. This is important to take note that it is used in conjunction with the clinical as well as radiologic information. So we generally don't make this diagnosis unless we have some corroboration looking at the clinical findings and other investigations. Management is follow-up with or without imaging or repeat ultrasound if there is any change in the clinical picture. There are several scenarios, several examples given within this non-neoplastic category. These include inflammatory conditions or inflammatory lesions, which can be acute or chronic, and of course chronic also includes infectious, non-infectious, autoimmune conditions, IgG4, etc. Silolithiasis, which can cause sometimes rather worrying reactive atypia. Sialadenosis, which causes bilateral, usually painless and diffuse enlargement, hence the clinical picture is very important, and this can be sometimes seen in association with diabetes, in alcoholics, malnourished patients, and on certain medication. Oncocytosis may also be included in this category, as well as the aspiration of reactive lymph nodes in the region of the salivary glands. Here is an example of a picture in the Milan system website, which is thought to be from a reactive lymph node. However, one can recommend flow cytometry if there are some warning signs, such as in an elderly patient, or significant lymph adenopathy, multiple lymph nodes, or if the nodes are matted. Moving on to the next category, which is AUS, which stands for Atypia of Undetermined Significance. I have paraphrased the definition. This is where a case lacks features for a confident diagnosis of non-neoplastic or neoplastic entities, and it does contain an atypical morphologic feature. So in other words, what we are saying is there are some worrying features and we cannot fully exclude a neoplasm. Again, we are required to submit the entire sample. The most likely outcomes for this, of course, is benign in the case of reactive atypia, or perhaps a neoplasm that is poorly sampled. And the authors suggest that we benchmark this to less than 10% of all salivary gland FNAs. Now, there are certain scenarios in which we can categorize a case as AUS. For example, if there is poor cellularity, we see very sparse basaloid cells, but we're not sure whether this is actually native basaloid cells, for example, in the case of sialadenitis, or is it a poorly sampled neoplasm. Another example would be when the sample is suboptimally prepared and there are a lot of artifacts. Or if we do see some cytologic changes, such as nuclear enlargement, prominent nucleoli, anisonucleosis, etc., and we're not sure whether this is reactive or neoplastic in nature. And also, occasionally, metaplastic changes can be quite worrying. There can be squamous, oncocytic, sebaceous metaplasia in certain benign conditions as well as salivary gland neoplasms. So differentials include neoplasms such as nucleoepithelioid carcinoma, pleomorphic adenoma, and also Warthin tumor versus just metaplastic reactive changes. In some instances, we can also encounter unusual findings such as aspirates with a few spindle cells, and we may not be sure whether these are mesenchymal conditions, reactive conditions, or actually neoplasms. This is actually an example of a case of nodular fasciitis that we had, which was confirmed on histology. There are other scenarios, again, when we encounter cystic lesions, if there is a significant amount of mucin, even in the context of no or very few epithelial cells, this may be classified as atypical. If there are few epithelial cells but not sufficient for us to definitively classify it as a particular neoplasm or a benign cyst, then again we can classify it as AUS. In lymphoid lesions, there is a wide range of differential diagnosis. Of course, they can be non-neoplastic, such as in chronic inflammatory or immune conditions or reactive lymph nodes, but there are also neoplasms, in particular the low-grade lymphoproliferative disorders such as the extranodal marginal zone lymphomas. These can be very tricky. It also is important to look for other elements in the context of lymphoid-rich lesions because, of course, Warthin tumor and even some malignancies like mucoepidermoid carcinoma and actinic cell carcinoma are well known to sometimes have lymphocytes in the background. The management for AUS, looking at the estimated or approximated risk of malignancy, it is thought to be about 20% given in the Milan, but the authors have also stressed that there is a lack of literature at the time of writing, and later I will quickly show a table showing a meta-analysis of the literature since the publication of the Milan system. Management-wise, definitely at least regular clinical follow-up. Imaging would be advisable, and if there are features concerning for malignancy, then a repeat tissue biopsy, whether it is FNA or a core biopsy or even a surgical biopsy. In cystic lesions, again, it is important to aspirate any residual solid areas under ultrasound guidance. And in the instance of atypical lymphoid cells, one should try to send material for flow cytometry as well. Now moving on to the neoplasm category, this, as you can see, has been split into two subcategories, neoplasm benign and salivary gland neoplasm of uncertain malignant potential, or SUMP. For neoplasm benign, the FNA actually is a very good test with high specificity for certain benign tumours. Of course, we must encounter characteristic features of these tumours before we can name them as specific entities, such as pleomorphic adenoma, Warthin tumor, and oncocytoma. And for mesenchymal lesions like lipoma, schwannoma, lymphangioma, and hemangioma, the latter two may be quite tricky to diagnose on cytology because of a paucity of spindle cells. Now, in the second subcategory, SUMP, this is where we are pretty sure we are dealing with a neoplasm. However, we are not able to distinguish between benign and malignant neoplasms, and usually in the context of SUMP, the malignant neoplasms would be low-grade malignancies, because if they are clearly high-grade malignancies, we would then safely classify them into the malignant category. So these include conditions or groups of lesions such as basal cell neoplasms, myoepithelial neoplasms, in which sometimes it is down to capsular invasion to decide between benign and malignant neoplasm, cyst adenomas or cyst adenocarcinoma. And the Milan proposes three morphologic subcategories, the first of which is the cellular basaloid neoplasm. And there are a lot of differentials here, which range from benign entities, pleomorphic adenoma, myoepithelial tumors, to malignant ones, basal cell neoplasms, which could go either way, adenoid cystic carcinoma, and epithelial myoepithelial carcinoma. The second broad morphologic subcategory is oncocytic or oncocytoid neoplasms, usually cells with rather low NC ratios. Again, the range of differentials includes benign conditions, oncocytoma, Warthin tumor, malignant conditions, secretory carcinoma, mucoepidermoid, and also myoepithelial neoplasms. And the final morphologic subcategory provided is the neoplasm with clear cell features, which again includes a range of differentials from benign to malignant and usually the low-grade malignancies. The management for this category depends on, of course, the subcategory. So if it is benign neoplasm, then usually surgical excision is indicated with the help of preoperative imaging. In the sum category, you can do a repeat FNA. Occasionally, ancillary testing may be helpful. Just an example, in secretory carcinoma, GATA3 mammoglobin may be helpful. Or if you have access to molecular diagnostic lab, the ETV6 NTRK3 translocation is quite characteristic. Imaging and, of course, excision with or without the support of intraoperative frozen section is indicated. Moving on to the suspicious for malignancy category, this is where the FNAs show cytomorphologic criteria that fall short in quantity or quality for a malignant diagnosis. And we should try as best as we can to specify the category of malignancy, so broad categories, whether we think it's a primary salivary gland tumor, a metastasis, or a lymphoma. The cytologic criteria are usually where we would see markedly atypical cells, but for some reason they are short of confirmatory. Maybe there is poor preparation, perhaps there is blood, perhaps the cellularity is very sparse, and maybe there are benign elements in the background. The risk of malignancy approaches 60%, and management-wise, ancillary testing may be helpful, immunocytochemistry or molecular tests, and of course imaging, which should also look for the possibility of metastases and surgery. Finally, the last category is the malignant category, and this is when there is a combination of cytomorphologic features that either alone or in combination with ancillary studies is diagnostic of malignancy. So the pathologist is certain that the features point to malignancy. There are times when we are not able to give the specific type of the malignancy, but we should grade whenever possible. And we should type it if we are able to, but we know that this is not always possible. So the Milan authors have divided the malignant tumors into three big categories: the low-grade tumors, actinic cell, secretory, and epimyoepithelial carcinoma. The high-grade ones, which are very easily recognized as malignant: lymphoepithelial carcinoma, small cell carcinoma, and salivary duct carcinoma. Differential diagnosis is high-grade mucoepidermoid carcinoma. And those of indeterminate grades, namely that they can have a range of different grades, such as mucoepidermoid carcinoma, adenoid cystic carcinoma, myoepithelial carcinoma, and carcinoma XPA. And of course, not forgetting hematolymphoid tumors. And finally, metastases. Now, the tumors that are not grayed out are those that usually can be recognized on cytology. So actinic cell carcinoma, the high-grade malignancies, adenoid cystic carcinoma, and carcinoma X pleomorphic adenoma. For the rest of them, these can be quite typically challenging to diagnose in cytology. So they may possibly fall into the non-outright malignant category. For example, secretory carcinoma or epimyoepithelial may end up being called SUMP. Mucoepidermoid may be called AUS or suspicious for malignancy, and myoepithelial again possibly SUMP. So it is important to know what cytology can and cannot diagnose outright. And hence, these are the tumors that are more readily diagnosable on cytology. The management, of course, is surgery, and the grade would help to dictate the extent of surgery and, of course, whether or not the nerve requires sacrifice. And not only that, the radiology is very important as well to delineate the local and the distant extent of the tumor. So here is a summary of the 6 Milan categories, and with certain benchmark suggestions from the Milan authors. Non-diagnostic, it is suggested to keep this below 10% of incidence. Risk of malignancy estimated to be about 25%. Non-neoplastic, risk of malignancy estimated at 10%. AUS, where this essentially means that neoplasm cannot be excluded, again benchmarked to less than 10% incidence. Approximated risk of malignancy 20%, and then benign neoplasm should have a very low risk of malignancy, whereas some should be expected to be higher, where we cannot exclude a malignant neoplasm. And then suspicious for malignancy, estimated risk of malignancy about 60%, and finally malignant, where we should try our best to grade the malignancy, and the risk of malignancy is about 90%. So now I'm going to include figures from a recent meta-analysis by Farahani et al. And these show the actual risk of malignancy of more than 16,000 cases that have been pulled from 92 papers, 92 publications. And we can see here the risk of malignancy for non-diagnostic is about 17.3%. This is the mean risk of malignancy. Non-neoplastic, 8.4%. The AUS risk is higher than what was expected in the original Milan system, but of course this really depends on the individual labs. And benign neoplasm, as expected, was low. SUMP, 41.5%. Suspicious for malignancy, yep, very close to 60%, and malignant, 91%. So this is my last slide, and this is essentially just a summary of the Milan system for reporting salivary gland cytopathology.